Thank you very much, GVK sir, and everybody in the 3D team for this opportunity and an interesting name as well as topic. Jugalbandi, I'm happy that an Indianized name has been given. As you know, it's usually associated, especially from my younger days, from the Doordarshan music days, national music thing. We always see two different genres of musicians performing together, individually initially and later joining together, and it's the fusion which gives that feel. I wish we will have a similar kind of discussion today. As you know, they are one of the greatest musicians in India. I think Dr. Vamsi Mohan sir may be here. Dr. Balamurali Krishna, need not know any other. Balamurali Krishna Garu, the Andhra link there. And Ajay Chakraborty, he is from a great Hindustani musician. His daughter is Kaushiki Chakraborty, very famous musician now. Incidentally, he is actually the Shishya of Balamurali Krishna. He is not only performing equally. So in that sense, Suresh represents Balamurali Krishna sir, and I represent Ajay. Hey, Suresh, you need not interfere for all this, okay? This is, Jugalbandi has already started. Huh?
No. So what Dr. Mahadevan he has told, it's perfect in order.
Sorry? Vamsi sir is here.
Vamsi sir, வீட்டுக்கு போயிட்டார் சார்.
வீட்டுக்கு போயிட்டாரா?
போயிட்டு வரேன்.
Okay. So we will start the session, and before that, one more coming to the academic part. Men also have problems. Equally.
Can't agree with you
and it so happens that men's problems are, especially with respect to, sir pointed out the bone health thing, etc., which is underrepresented. We had a meeting a couple of years back online during the corona time in our department, endocrinology. Okay, so we will see how men's problem is also not well addressed many times. So I will start off this discussion on hypogonadism in diabetic patients. Our focus will be on that. Even though the invitation prints too many things on a classic endocrine approach, but that may not be of use to a physician practitioner, and I spoke to GVK sir to slightly modify. We will focus only on the perspective of how we approach hypogonadism in a patient with diabetes, obviously here a male with diabetes. So from the understanding point of view, the gonads are divided into, especially the testis, into the hormonal part and the spermatogenic part, and whatever we discuss today will be focusing on the hormonal part. That is the usual way we define hypogonadism. There are many patients who have only spermatogenic problem without hormonal issue. That will be beyond the purview of these kind of discussions. So, and from endocrine parlance, any endocrine pathology, organ specific, is usually classified for conceptualization purpose as primary and secondary. Here, secondary does not mean secondary to another etiology. Secondary means the pituitary or hypothalamus is involved. Primary means primary, the endocrine gland is involved. So here it will be testis. So anybody with a testicular disease and due to which the testis is not functioning well will be called primary testicular dysfunction. And anybody with a pituitary hypothalamic issue, whether organic or functional, will be called secondary. One of my professors used to say, when in these discussions, I can spoil anybody's Sunday with these kind of slides. We have busy slide reciting all the causes, which we all know from our undergraduate days: congenital, acquired, primary, secondary, all this, you can name it, you can take any standard textbook to see this. However, the focus will be on only one aspect here, which is directly pertaining to metabolic disorders affecting the hypothalamo-pituitary gonadal axis, specifically testis for today's discussion, and that too, how obesity, diabetes, the insulin resistance spectrum, including OSA, involve or affect in a functional, reversible manner this testicular pathway is what will be our focus.
Dr. Mahadevan, 1 minute. What is hypergonadotropic and what is Just inform them.
As I said, the primary and secondary. The primary means testis is affected. So we should recollect our undergraduate days in endocrinology, there is a negative feedback. When testis is affected, the pituitary will affect to stimulate the testis. So the gonadotropins, LH, FSH will go high. That is called hypergonadotropic hypogonadism. In pituitary pathology, testis again will be low in its function, but because there is no drive from the pituitary, that is called secondary or hypogonadotropic hypogonadism. In the hyperona patients could hypothyroidism, I won't tell them, sir, hypo or hyperambanga. She will be a hypothyroidism patient on over replaced thyroxine. Now, in the Vate, Tamil na solren, ongaloda thyroid sorapi kureivaga vele seigiradu, abdin soli pargandra. And now the TSH low are the hyper. Anyway. Here we won't go into that. The finer aspects of this are beyond this 30 minutes discussion, but I am coming to the point that here obesity and diabetes definitely affects this pathway, and I will go give it over to Suresh ji for the next discussion on what is the link, further elaborating the mechanisms behind this.
Good morning and thanks for the wonderful opportunity. I think when the type 2 becomes insulin, they say type 1. Sir, type 1 So anyway, so it's a fascinating science, how the insulin resistance and how the diabetes and hypogonadal link is there.
If you are comfortable talking in the mic, you can walk around.
It's okay, it's okay, it's okay.
I will play.
Yeah, it's okay, don't worry. So, so I worked with a couple of guys who has got a special interest in hypogonadal, Pierre Boulou in Royal Free, and Wu, Frederick Wu, but I've listened to him during the work, primary work of hypogonadal. So basically the science has evolved, and we just concise what is the link as a whole of a diabetes along with a hypogonadal. So uncontrolled hyperglycemia, I'll come to the mechanism. Sri has mentioned briefly, but I'll come to the mechanism. But type 1 is a no-brainer, that is an autoimmune condition. And then steroid excess, either it's external suppression leading to diabetes, and that's one more link. And then infiltrative conditions, which happen to be one of my interests with lymphocytic hypophysitis, IG4 infiltrates in pancreas and pituitary, and quite a few other conditions like hemochromatosis. So the hypogonadism on diabetes, the body composition is very, very important. The fat cells, which works as an organ, and that fat cell has got aromatase, and it comes into estrogen, and that will talk to the pituitary, and insulin resistance plays a big role. But the low energy, and there is a topic where Kumar will be talking about with the muscle mass decrease, how the GLUT4 receptors doesn't work. And then obstructive sleep apnea, Sri has mentioned early, and then atherogenic dyslipidemia. So this is the cartoon I want you to understand. Kisspeptin is a one molecule. Jyotish George, one of my colleague, I think he's in pharma industry now, but I think he's done extreme work with kisspeptin as a peptide. But I think there is a good super duper connection of fat cell with IL-6. We have seen quite a lot during COVID time, how the inflammatory cytokines work. So inflammatory cytokine talks to the pituitary, and then the pituitary hormone levels goes down, and that will eventually affect the testosterone production. And this is the same picture, which is so complex. Sri has made it a very nice one. With sex hormone binding globulin, with the fat goes down, and then you eventually, with inflammation and other things, the FSH secretion and the total testosterone index is just a really fascinating thing to know. Just measuring a testosterone is not good enough, and I leave to Sri to tell about how we should measure testosterone, and that is very, very important. People come up with saying that one level of testosterone is 230, whether I should start or not. No, there is a way to do it. I'll leave it to Sri.
Even in the previous Jugalbandi discussion, this should be mentioned repeatedly, re-emphasized that even though we order testosterone, and obviously nothing is done free, we all know the free here means it is free from binding to any protein, globulin or albumin, and the gold standard for textbook MCQ purpose is equilibrium dialysis and LCMS, which we rarely get it done that way. So for all practical purpose, if one take-home point from this discussion today, from the testosterone assay point of view, if all of you have to take home, is please do not do free testosterone. Please do only total testosterone, if possible, along with the sex hormone binding globulin. Both are measured very well by a good lab. So let us do only that. And we have to remember how obesity, diabetes, and all the other metabolic conditions affect the SHBG, and how that can alter, that can go on and on, we can discuss as we go along. We can, for academic purpose, calculate what is called free androgen index from these two, just like how with insulin and glucose you can calculate HOMA, etc. So that can be done. So please do not do free testosterone for all practical purpose unless you know what you are dealing with. And SHBG can get altered with multiple things. I have specifically looked into a few things to see here. You can put at how many of our patients will have early CLD today. NASH and NAFLD are most common diagnoses today. TZDs, so many drugs which can interfere, thyroid and estrogen. I remember Jayashree madam mentioning about estrogen and its effect on these binding globulins, and decrease in SHBG by multiple mechanisms. So we should remember, it's not easy. Sometimes, we oversimplify in these kind of forums, and in a given patient, we may unnecessarily over or under treat. Both can happen. So kindly look into all this before interpreting low testosterone. Very common. A male, and he comes with a testosterone report, and I see a very big chain of labs, very famous name, I don't want to mention here. They do testosterone in females also. Big package. 68 test, 2000 ரூபா. 2 பேருக்கு பண்ணா Sunday இன்னைக்கு free, 2 பேருக்கு பண்ணா ஒருத்தருக்கு free, whatever they do, and they do testosterone also, and அதில் ஏதோ ஒரு erratic value will come, and the patient will be already on, like for example, PCOS girl lady can be on finasteride, she can be on testosterone level will be high, a male can be on some other spironolactone or something and he'll be on testosterone low. All simple things are overlooked. So obesity, type 2 diabetes, what have we learned till now is, does it cause testosterone deficiency? There seems to be a setting in which functionally the testosterone can go low. Whether it is causal, which is causing what, can be debated more and more, but there seems to be definitely enough evidence to say pathophysiologically, definitely this can go low. Now, further, it will be elaborated by Suresh.
Yeah. So it is beyond a doubt there is a link, and how, whether chicken or egg, whether diabetes lead to hypogonadism men are more prone for diabetes. We'll come to that. I think we'll just start with the case scenario. 41-year-old, type 2, A1Cs are not ideal, and we got a diabetic dyslipidemia, SSRI for 3 years, and BMI is 31, and the statin and usual as suspects are there. But I think he is very good compliant patient for a change and completing, but I think there will be normally a hesitant question if it all comes out. Sometimes it doesn't come out, we have to ask the question. So after further questioning, ED was discovered, and just immediately people start doing, well, I think PDE5 inhibitor just start immediately, because we don't have time in the clinic for 40-50 people, and we don't have time. So, but
sorry
it's
to interrupt.
Yeah.
The audience should not take home a point that, see, ED is one condition where any physician will think of hypogonadism, maybe a hormonal issue. The point we are trying to make, and I'm sure in another 15 minutes you will realize, is even without any pointers to sexual dysfunction, still low testosterone can be a part of obesity, diabetes spectrum. And that is when this fellow is giving a clue.
Well, that is when I think we should be very careful in measuring the assay. Sriram has come up with how to assess the testosterone assay, which is very, very important. Don't get it with one readings. Was it appropriate? Was there any other etiology for his ED? And what are the assessment that we need to do as a clinician? What you normally get is there'll be a sarcopenia. I'll show you a picture, but I think these are the things. Don't think all the irritable men are hypogonadal though, but yeah, so there'll be some depressed men are, but so there's quite a lot of other things which we don't discuss publicly, I don't know, for a very long time, and still it's not happening. But the younger generation has come out, so probably they are doing it. So these are some of the obvious things that we don't discuss in detail.
Sorry to interrupt. Yeah. The interesting part here is many times the patients themselves go through the net. They fulfill that Adam questionnaire is the standard internationally recognized. And already he gets a testosterone also done. And
that's what happening. I mean, you all agree. See, everybody is nodding the head. This is all happening in our day-to-day practice. we just people, any Tom, Dick and Harry prescribes it, and even the gym guy is prescribing. So they are doing it in a big way, and marudin testosterone eduthu marudi inga varuvan bro. So I think the gym guys especially, I've done a clinic with all these post-exercise fellows affected with hormonal things. There is a package of cocktail. Deca.
Genuinely requiring patients so that testosterone sales maximum happening in the gyms.
Gyms.
Not only testosterone, our namaloda famous
insulin mixed cocktail. So there is a cocktail that they give in the gym, and I used to do that clinic, which is hormonal affected post giving all these abuse drugs. That one, the gonadotropin is the main hormone that gets suppressed sometimes throughout life. These young guys take it for a while and that gets suppressed. So the point is, there are a lot of abuse, not necessarily medically, but from other colleagues as well. So physical science wise, not all the abdominal obese men are hypogonadal, so I'm not hearing controversy here, but
one small, especially being in a medical college, I have to definitely, I cannot go past this slide without mentioning, is the most important is to examine the testis. I'm reminded of my professors repeatedly. You strip the page, you have to examine the testis. Sometimes a smaller testis, soft testis. The simple logic, bedside teaching is,
you will be shocked.
The testis normal consistency is like the contracted thenar muscle. You see an acquired cause of hypogonadism, invariably it will be soft. You see anybody. And you can see the capsule of the testis and the testis material inside it. So it will feel soft. By repeatedly feeling, you will know. And you will not find the size is variable, especially in Asians will be small. So body is small, we have to go by volume, for which endocrinologists, the only instrument we use is orchidometer.
I was about to say that I think Pierre Boulou, one of my professors in Royal Free, he's just maniac about this orchidometer. He will carry it and then he will palpate, and he would go to any medical students explaining it, saying, because throughout his life he spent in hypogonadal men, but I think he just carries this orchidometer.
If at all I can add, that male who comes with that one random value of testosterone, if you examine, and if you doesn't have these 2-3 things, then you can easily reassure him.
Absolutely.
And it's more likely elaborate. Ademari gynecomastia, invariably there will be a lipomastia component. It's better to get it. So it's not, they are obese. Obesity leads to increased estrogen in a male, and there will be a fatty deposition also on top of the gynecomastia. So gynecomastia does not mean anybody with a protruding this chest area does not mean it is gynecomastia. It could be simple fat.
So if you can imagine fat as an organ, and then the testosterone comes in, aromatase enzyme is there, and that will convert the testosterone to estrogen. So when the plumpy male is there, they will have more estrogen that talks to the pituitary and make them one of the hypogonadal symptoms. So there are a lot of symptoms that we need to see, and there is a definition for that along with the symptoms. And we discussed, Sriram has discussed this primary and secondary. Dr. Shanmuel has asked, and that's hypergonadotropic hypogonadism and hypogonadotropic hypogonadism, the secondary. These are the very, very important investigation. We should concentrate, and we have to do the work properly. So if you do the work properly, you will get the diagnosis. Again, just to show this is the way to do that patient with a proper assay. I'll leave to Sriram to discuss about how deficiency is the common between these two.
Dr. Suresh, what should be the appropriate timing for collecting the sample of blood?
Yeah, my boss, my professor used to say, the 7 o'clock edge tech or shaving இது வரும். அதே 7 o'clock நான் வெச்சான்னு கேட்பார் bedside roundsல. அதனா மார்னிங்ல தான் பண்ணனும். டெஸ்டோஸ்டெரோன் அப்பதான் அதிகமா இருக்கும் to remind shaving, So morningல தான் பண்ணனும், fastingல தான் பண்ணனும், அப்பதான் கரெக்ட்டா வரும். All other value, all these, most of the hormones have a diurnal variation, and thankfully these are all morning samples when the labs are working. And how common? Thankfully in the last 2 decades, for every talk like this, we have a lot of Indian data, thanks to our colleagues everywhere. We were also part of one study, that last one published just last year. Enough of data in diabetes and testosterone, including SHBG, further workup. Prolactin, free T4, TSH should be added to any gonadal hormone estimation. Cutting across any such study, all these are Indian studies, by the way. It can vary anywhere from 7 to 8% to even 22%, depending on whether you did SHBG along with it, free androgen index, and for research purpose, they have done free test also as part of it. So you can take it that around 10 to 15% of these diabetic men who were part of these studies had documented biochemical low testosterone. Whether you evaluate further, use your clinical judgment, and as usual, you pool all these studies. This was one reasonably older meta-analysis where again they showed a big prevalence of low testosterone. So what do we learn from all this is low testosterone biochemically with variable symptoms is not at all rare among our diabetic men. How proactively you go, how much you evaluate, use your clinical judgment. So having said that, so how do we treat if at all you diagnose? Suresh.
So we got beyond doubt that we're going to work on a case with any symptoms if they mention, and once we work on it and how to diagnose and then go ahead with the treatment. So this is one of the old studies again, just to show 52 weeks treatments, almost like an year, with transdermal testosterone reverses metabolic syndrome. So the point is, replacing testosterone, how it helps the metabolic syndrome and then diabetes. So that is the point. So whether it is possible. And this is from, again, Hugh Jones from Yorkshire in UK. So that proves almost like 6 months transdermal testosterone replacement has got a beneficial effects in the insulin resistance, and then the total LDL level, lipoprotein A, and then sexual health. Obviously, that is the reason you give it after all. But there are a link with the Kapoor has done huge amount of work. If you go into the literature, he's done most of the works actually. So it is like a meta-analysis, and if you see the review article shows that hypogonadism is associated with insulin resistance, number one, and then testosterone replacement inhibits hyperinsulinemia, and then the cardiovascular events like the parameters comes down, and eventually cardiovascular events is reducing. So how do we replace it? Whether we should just go for tablets or whatever, but the whole idea is just to maintain the symptoms what they came in for, and of course you have to treat the patient in a big way to maximize the benefit in terms of muscle and bone and cardiovascular health, and we shouldn't over treat it, and that's the main thing because it's a hormone. So intramuscular injection, topical one, and topical gel is also available, and that is slightly expensive, but I think it's not picked up in a big way in India, but it's mainly for the hygiene reason. It's sticking all around, but they prefer injections. I give more of Serinos, which is more of a 3-monthly depot injections, which works very well. And the first injection should be within a month or 2 months gap, then every 3 months is okay. That is testosterone injection. And we should ideally ask for a OSA or urinary symptoms, because the urologist won't like you. I think if you start giving and the prostate goes up, you have to just check the PSA levels, and also you have to look for a few other things, which is the polycythemia, that blood cell goes, the size of the cell goes up. So these are the common things, and I'll just hand over to Sri for next 2 minutes, so we'll finish in 5 minutes.
This is in summary of all the studies which have been done recently after 2015. Only I was reminded of this vitamin D studies when I was going through these articles. So vitamin D is associated with everything under the sky, but when you gave vitamin D, the outcome was not as good as that. And in vitamin D in diabetes, they will discuss vitamin D kudutha insulin resistance and agum, glucose koraima, HbA1c koraima. Anyway, adhe mari they had given testosterone. You should remember, if at all, T4DM is one study which I think, if academically somebody is oriented, it's worth remembering that name. Testosterone for diabetes. That is, they took men who are pre-diabetic and high risk for going into diabetes and gave testosterone. 1,000 odd men were taken between 50 to 74 with low testosterone. amazing outcome. Can you imagine 40% reduction in the prevalence of diabetes in the next 2 years? Even the famous DPP study also did not show that 36% and 51% in the lifestyle. So, but they showed that lifestyle is also important. Then they, as usual, once you give that, then you have to worry about side effects. That is the age when prostate comes up and other issues are there, obviously monitoring. Then in these studies, a sub-study of diabetes was done. In all these studies, surrogate markers of diabetes, especially glucose na inga paapanga, HbA1c paaka matanga. I think Dr. Lakshmi mentioned in the previous talk where anemia and HbA1c. Here, testosterone increases the hematocrit. So newer blood is formed. HbA1c will not be a good marker for these studies. So they go by only by fasting glucose. Very interesting point is testosterone definitely in all these studies did not cause any weight reduction because it reduced the fat mass, increased the muscle mass, nullifying the fat reduction. So if at all, or good reduction. So what we are seeing now is definitely there are some metabolic benefits. Diabetes, doubtful. And you can see here, how many of us will dare to prescribe testosterone to reduce the diabetes? I don't know. You have to use your clinical judgment, but there are enough indicators towards that. But for diabetes purpose, we need more data both from the CV outcome as well as cancer outcome from the prostate and other issues. So that is the, in nutshell, what we are seeing in testosterone and diabetes. So as in Jugalbandi, we will...
So, innor angle la pathina, when you give testosterone, he will be happy. Every point of view. So then he started doing the exercise.
Unga patient ku ennachu kadachila? This patient who came with you.
So patient he opened the mouth and he got the diagnosis, and the pituitary, of course, you have to do for the secondaries, and PSA is normal, so I am happy because if PSA is abnormal, I won't be happy. I don't know what to do. But anyway, so that is what it is, and we've treated, and he's happy patient, and he still comes to the clinic. So that tells you something. So in summary, you want to finish or? Okay. So,
Dr. Suresh,
1 minute more.
I need one clarification.
Timer
What are the good, predictors for good response with reference to testosterone therapy?
Coming to your clinic. Our clinic vandale good response. But anyway, so I think.
No, based on the testicular size or the volume, or based on the testosterone level,
if you do
or
have
the
time
age group,
Yeah, I understand. If you do have time to spend with the patients, which we all don't have, so then the ideal is just to examine skeletal muscle strength and then test his volume and stuff. But it will be mainly patient's symptoms, which will exponentially will have difference if he's real hypogonadal and these androgen deficiencies creating the symptoms, then he will benefit from hugely symptom-wise through the replacement. So
will there be any change in the consistency of the test is what Dr. Mahadevan has described after
testosterone therapy, the gonadotropins will normally get suppressed and your testes will become softer and smaller. So
that should be the key messages, sir, because they expect.
Ana adha monitor panna matom. Adults la adha monitor.
Adanala ellathukkitte pant outhingna problem airu sir. So I think the androgen level is very important to treat, and it is very important. I think the patient will start feeling better, even the depression and everything. You can take the SSRIs out and it will have an impact in a big way. So in this 30 minutes, hopefully we have created some signs that there is a link between these two, rather than monotonously looking at a patient in that's a timer. So monotonously looking at blood sugar alone, glucose-centric, we have other things to look at which might be helping the patient's well-being, that eventually will turn out into exercise and lifestyle, and hopefully he'll be a good patient for you.
Thank you, Suresh. All is well that ends well. We have opened up some Pandora's box. I suppose a lot of questions are still remaining. In no way this will be a replacement for, we
Absolutely
follow in
not.
endocrine practice proven pituitary pathology patients, pituitary adenoma on follow-up, who are on testosterone replacement. அவங்களுக்கு diabetes வரலாம். அதில் testosterone கொடுத்து தான் ஆகணும். There is no way.
So,
The routine diabetic patient, whether how much will you go for, use your clinical
So
judgment.
whether the impact what we have done today, it will be showing in orchidometer sales in Chennai tomorrow.
Orchidometer
Orchidometer sales in Chennai based பண்ணி தான் நம்ம
not routinely available. You can't get it.
இல்லைங்களா?
சுரேஷ்
கை தான் ஆர்கிடோ மெஷர் பண்ண முடியாது சார் கையில்.
சுரேஷ்
கன்சிஸ்டன்சிக்கு தான் அது சொன்னேன், சைஸுக்கு அது.
சுரேஷ் பாலமுரளி கிருஷ்ணா, ஒரு நாள் போதுமா இன்னொரு நாள் வேணுமா?
சார் ஒரு நாள் அது அவர் தான் பேஷண்ட் தான் சொல்லணும் சார், அவங்க வீட்டில் தான் சொல்லணும்.
Sir, please.
I think most of the diabetics have NASH. If you could measure now FibroScan routinely in the clinic, NASH, diabetes, testosterone level, if you could measure, as the NASH advances, the testosterone level comes down, especially in men.
Yeah.
And that's point number one. Number of alcoholics, cirrhosis.
Yes.
Cirrhosis, diabetes, testosterone levels, all secondary causes. One should really remember, before you treat a patient,
All are
testosterone,
estrogen related.
look for the liver. I've been doing now for 100 cases. I think I may publish it, testosterone and the advancement of NASH in men with diabetes.
Yeah, exactly the fat mechanism. So it's a no-brainer that when the fat goes up, again it converts to estrogen and then you will have hypogonadism. And same thing with the liver disease, will all the important proteins, albumin and globulin all will come down and you will have sorry.
Sir,
Okay.
with the chair's permission.
Chair permission.
It's open for discussion.
Always this reproductive health which takes backseat when we examine. Like sir, my doubt is whenever we have this diabetic seat,
It has
that's what sir, in my clinic always I keep Thursday that we have this examination. To my surprise, always first women come first, then they bring their husband. Like the things which happen. My doubt is whenever we are giving this, first is broad question sir, whenever a patient with diabetic with erectile dysfunction is there, do we have to give him first testosterone or should we give the Tadacil, all this drug? And second is, whether I diagnose any diabetic patient, when should I give the testosterone level therapy?
ராமாயணம் ஃபுல்லா
கேட்டுட்டு அதான் இது பண்றாரு. அதுதான்
இல்ல
இப்போ
sir.
நம்ம லெக்சர் ஃபெயிலியர் ஆனதுக்கு முதல் எவிடன்ஸ் கிடைச்சிருச்சு. குமரவேல் ஒண்ணுமே இன்டர்வியூன் பண்ண மாட்டேங்கிறாரு. குமரவேல்
Boss, erectile dysfunction, one of the etiology is hypogonadism, which is testosterone deficiency. Please look at all other factors. Lastly, you come to hormone deficiency as a cause of erectile dysfunction. Most commonly in a diabetic patient, routine run-of-the-mill general clinic, erectile dysfunction is not due to hypogonadism. This is number one. நீங்க அப்புறம் என்ன கேட்டீங்கன்னா testosterone முதல்ல கொடுக்கும். Because that's less common. Please, even though we are discussing it in such a big elaborate manner in these kind of meetings, நாளைக்கு போய் முதல்ல எல்லாருக்கும் testosterone கொடுப்பேன், எல்லாம் நாளைக்கு நேத்து மீட்டிங் அந்த மாதிரி
பேண்ட் அப்பனா அவள எல்லாம் ஓடிடுவாங்க சார். அப்புறம்
Illa, probably my question I was unable to express properly sir. What I was asking is, whenever I give testosterone, what all things I should keep in my mind? Like you told polycythemia, all the things you told. Other things. Those
symptoms, vague symptoms. You just like in ED talks, what will they tell? They'll say you proactively ask for, in the privacy, if he opens up, if he gives symptoms which are related to either sexual dysfunction or he gives symptoms which are related to sarcopenia, weakness, that ADAM questionnaire will be a good screening tool for you. Then you check.
For answering Sir's question, the follow-up with the ADAM questionnaire will be a right way to do. And the other things that you should check is the PSA, hemoglobin, and ask a history about obstructive sleep apnea because the testosterone can worsen it before getting better. So OSA can be one of the things, and then obviously an ultrasound just to check for the prostate would help along with PSA. Sir.
I think one last question, sir.
Sir, endocrinology point of view, you do all hormone investigations and assess that. With all this, everything is normal. Still he has got a erectile problem.
Then PDE5 inhibitor, then I think Dr. method. Where all PDE5 inhibitors.
அதுக்கு தான் எண்டோக்ரைனாலஜிக்கு முன்னாடி ஒரு வார்த்தை அப்பப்போ சேர்த்துமோ நியூரோ எண்டோக்ரைன் அப்படிங்க.
ஆமா.
நியூரோ சைக்கோ நியூரோ எண்டோக்ரைன்.
எல்லாமே பிரெயின் இல்லைன்னா அப்புறம் ஃபங்க்ஷன் தாங்க சார். அப்புறம்
the organ.
Brain.
சந்தான சார் மாதிரி சீனியர் ஃபிசிஷியன் நீங்க சார் எல்லாம்
90% பிரெயின்ல தான்
பாருங்க. டைம் இல்லன்னு அவசரமா டாக் முடிக்கிறோம். டைம் இல்லன்னு தான் பேஷண்ட்டை வெளியில அனுப்புறோம். டைம் ஸ்பெண்ட் பண்ணால் யூ வில் கெட் டு நோ வாட் இஸ் த காஸ்.
ரெஸ்பான்ஸ் as well. அதே மாதிரி தான் ஹோல் லாட். தேங்க்யூ
Thank
தேங்க்யூ
you,
ஸோ
sir.
மச். வி டோன்ட் டிசர்வ் கிளாப். நாங்கள் ஃபெயில் ஆகிட்டோம். பட் anyway.
Thank you, sir. Thank you, Dr. Suresh and Dr. Sriram. It was a wonderful lecture. May I hand over the mic to the organizers.